Hello, this is Dr. Michael Overman from the MD Anderson Cancer Center in Houston. Welcome to this educational activity on exploring the therapeutic potential of personalized therapy with emerging immuno-oncology strategies in colorectal cancer. Joining me in this discussion is my colleague from our Department of Pathology, Dr. Melissa Taggart. Welcome, Melissa.
Thank you, Michael. I look forward to our discussion.
The following audio is from a two-part video panel discussion with Dr. Michael J. Overman and Dr. Melissa Taggart. This audio is part of a certified educational activity titled Interdisciplinary Approaches to Personalizing Immunotherapy in Metastatic CRC Using Advances in Molecular Markers. To access the entire activity and complete the post-test, please go online to www.peerreviewpress.com/MTU. A printable monograph, slides, practice aids, and other features are also available.
Now let's begin by looking at the pathology perspective on biomarker analysis in colorectal cancer, with a focus on deficient mismatch repair. Globally, colorectal cancer remains a major healthcare problem and is the fourth leading cause of cancer-related death. Historically, treatment of advanced disease has consisted of multi-agent chemotherapy with the incorporation of anti-VEGF and anti-EGFR therapy in recent decades. The advent of anti-EGFR therapy with cetuximab ushered in an era where treatment in some cases could be guided by the presence of molecular features such as KRAS mutations. Subsequently, it was shown that expanded RAS testing was also useful in helping to guide therapy selection with agents such as cetuximab or panitumumab in metastatic colorectal cancer. Other biomarkers have also been established in the colorectal cancer setting. For example, approximately 4% of patients with metastatic colorectal cancer have a high degree of microsatellite instability due to a deficiency in DNA mismatch repair system. Some researchers have initially shown that patients with colon cancer who demonstrated high-level microsatellite instability high or defective mismatch repair received no benefit from fluorouracil-based adjuvant therapy compared with patients exhibiting microsatellite stable or proficient mismatch repair. Subsequently, a major study by Dan Sargent and colleagues showed that determining mismatch repair status offered the potential for a more tailored approach to adjuvant therapy in patients with stage 2 colon cancer. As you can see here, adjuvant therapy significantly improved disease-free survival in patients with proficient mismatch repair, while no benefit was observed in patients with deficient mismatch repair. In the wake of this evidence, testing for mismatch repair status has been incorporated into pathology testing guidelines from many societies and cancer organizations. Melissa, would you be able to take us through some of these current recommendations?
Thanks, Michael. I'll start with a summary of what societies like the College of American Pathologists and the American Society of Clinical Oncology have jointly recommended for mismatch repair testing. So as you can see on our slide, all patients should be tested at diagnosis. And currently, we have two tests that are recommended for evaluating deficient DNA mismatch repair: immunohistochemistry on formalin-fixed paraffin-embedded samples, and PCR for MSI analysis. And of course, we should all follow best practices. We should have validated tests, we should have reasonable turnaround time, and we should produce understandable standardized pathology reports. Other organizations, such as the NCCN, have also published recommendations for mismatch repair testing in colorectal cancer. The NCCN recommends that all patients with a new diagnosis of colorectal cancer be tested. Also, family history should be taken, and individuals meeting Bethesda guidelines or Amsterdam 2 criteria as possible Lynch syndrome patients should also be looked at, and possibly even additional tests should be implemented. And of course, best practices should be followed in clinical and anatomic pathology. Testing should be performed in a CLIA-certified laboratory. And for patients who have tumors which do not express MLH1, they should also be tested for BRAF, V600E mutations, and/or MLH1 mutation hypermethylation.
Thank you, Melissa. Would it be possible to go through some examples in the laboratory side? Could you show us some of these real-time situations in the lab?
Sure, I'd be happy to. So we're going to go through the testing that we commonly do in the lab. And like I said before, it consists of two basic tests: immunohistochemical stains for the DNA mismatch repair proteins, and microsatellite instability analysis by PCR. And as you can see, both are highly sensitive and specific. However, they test two different things, and that's important to recognize. They also have pros and cons, which you should take into consideration when you're testing your patient. We're starting with immunohistochemical stains. You can see that one of the main reasons we use this is that it's very easy to do. You do not need normal. There's a fast turnaround time. It's cost efficient, and most pathologists have access to this testing in their laboratory or in a reference lab. It also, and probably the most important thing, is that it identifies the target gene that's abnormal. It does have some pitfalls, though. Expression of non-functional proteins can be seen. So even though the protein is expressed, it doesn't mean that it's functional. Decreased expression is also seen in some treated tumors. So this comes into play especially in colorectal cancers, which in some areas have standard of care of chemoradiation therapy prior to excision. Also, variable staining patterns can be seen, and this can be due to a number of reasons. Fixation can be a problem, and just some additional areas where the tumor doesn't completely stain. Also, chemoradiation therapy can cause these problems in variable staining patterns. And then other things that we have to deal with is limited tumor, especially when you have the added problem of variable staining. So the other test that we would perform would be microsatellite instability analysis by PCR. And again, it is highly sensitive and specific. However, it tests a different aspect of the disease process. It actually tests functionality rather than expression of the protein. And as I said before, you may have a protein that's expressed but not functional. So it gives different information from the immunohistochemical stains for DNA mismatch repair. It is highly reproducible. The pitfall, though, is that you may need normal tissue. Some of the assays do require normal tissue where others do not, so it will just depend on what your lab is using. One of the other pitfalls is that mutations in MSH6 may actually show you microsatellite stable or microsatellite instability low tumors. Now, some newer methods are coming out, but they're not standard of care. But just to let you know of some of the things that have been seen, especially in the advent of next-generation sequencing, we have seen that analysis of microsatellite loci, when you do targeting sequencing of known loci or evaluation by informatics tools, can identify microsatellite instability high tumors. But more recently now, we have seen that even just looking at tumor mutational burden can identify DNA mismatch repair deficient tumors. Now let's discuss immunohistochemical staining for mismatch repair proteins in a little more detail. As you can see here, we have a schematic of how the proteins actually work, because it's important to understand how the proteins interact so that we can interpret the immunohistochemical stains. You can see that MSH2 and MSH6 pair together, as well as MLH1 and PMS2. It's important to know that there are major proteins and minor proteins in this complex, and the major proteins will be MLH1 and MSH2. So if these proteins are not expressed, they can never pair with their partners, MSH6 or PMS2. However, if there is a problem in one of the minor proteins, the major proteins will still be expressed. And here's what we see in the lab. So we're looking at immunohistochemical stains for two of the DNA mismatch repair enzymes performed on a section of colorectal carcinoma. The one on the left shows retained expression of the protein, brown staining, in both the tumor nuclei and the normal adjacent stromal nuclei. The one on the right shows loss of expression of the protein in the tumor, while the stroma next to the tumor acts as a normal control. Depending on the proteins which are lost, we can pinpoint the gene which is defective. So I just showed you examples of when the DNA mismatch repair enzymes are expressed and when they're lost. And we would use the pattern of each of the 4 immunohistochemical stains to determine which protein is at fault. If we have loss in MLH1, then we should lose PMS2. However, if there is a problem in PMS2, we would still have retained expression of MLH1. Now we can look at a PCR assay. The PCR assay tests loci that contain microsatellites. These are areas of nucleotide repeats in the DNA which are prone to replication errors. The loci are tested in both tumor and normal tissue from the patient, and any changes in the number of peaks or shifts of the peaks indicate a replication error. We generally analyze a panel of 5 or more microsatellites. Depending on how many errors we detect will determine the level of microsatellite instability. So, no allelic shift, then it's a microsatellite stable tumor. If we have allelic shift in less than 30% of the markers tested, it's an MSI low tumor. If there is allelic shift in greater than 30% of the markers tested, then it's an MSI high tumor. So Michael, we can do all of these tests in the lab, but it really does require a clinical pathologic correlation when we're looking at individual patients. So what we would take into account is age of the patient, patient history, any type of synchronous tumors, metachronous tumors, any other Lynch syndrome type tumors, family history, and sometimes even the histologic features. And even though your testing may show different results, if there's a body of evidence that this might be a Lynch syndrome patient, you should really go on with genetic counseling or further testing.
Thank you, Melissa. Now that we've seen how to interpret mismatch repair and MSI tests, let's discuss some practical points on how pathologists and oncologists can work together to ensure optimal pathology testing for our patients with colorectal cancer. The CAP guidelines recommend that all clinicians involved in the patient's care, including pathologists, have the capability of ordering mismatch repair MSI testing. There are, however, several issues to consider that might determine who orders a test or when a test is ordered. Melissa, what are some of your thoughts in regards to tissue adequacy and tissue collection that factor into kind of test ordering?
So you bring up a lot of good points. We do actually, as stewards of the tissue, need to make sure that there's adequate tissue for the test that you want to order. When we do not have the appropriate amount of tissue, or there's too much necrosis or other factors, it certainly can give you erroneous results. So it may be that you may order a test and I may cancel the test or ask you to get additional samples so that we can actually do the test properly. The other thing that you brought up was that pathologists now, by these guidelines, are empowered to order these tests. Previously, it really was clinically driven, and there's been a number of studies actually saying that we should be ordering these tests on a universal basis, but it really hasn't been implemented of who should be ordering the tests.
So are there some critical features that kind of would initiate that ordering on your side?
Sure, and this is a good point. Really, pathologists and oncologists and surgeons really need to work together in their institution to make sure that this testing, one, is going to get done, and two, that we're not over-testing. We certainly don't want to duplicate results. And also that the testing results get followed up, either by the clinician and especially by genetic counseling if they're abnormal. So what I may see that may prompt me is DNA mismatch repair enzyme deficient tumors may actually have very distinct histologic features that I may pick up actually on the slide and suggest to do this test, or may even reflex the test myself.
Okay. Thank you, Melissa. That was very interesting. Now that we've seen what mismatch repair testing looks like, we'd like to preview the next segment of the program by offering some thoughts on mismatch repair status and what it may mean for the future use of immune therapy. At the moment, most data suggests that deficient mismatch repair or microsatellite instability high colorectal cancer is associated with elevated levels of tumor neoantigens and tumor infiltrating lymphocytes, as well as upregulated expression of checkpoint regulators in immune cells, including PD-1 and PD-L1. This is shown in more detail here on the slide. And what you can see is that we're really critically focusing on this interaction that really occurs between the T-cell receptor, the antigen, and the MHC presentation mechanism. And that interaction is what really drives T-cell response. The key is that along with that antigen interaction, there has to be co-signals that go along to tell the T-cell what to do. And there are certain signals that actually turn off this immune system and this turn down the T-cell activity. And those signals are CTLA-4 and the PD-1, PD-L1 interaction. And those are inhibitory signals. And so the immune therapy that's out there are actually blocking these inhibitory signals to enable a reaction of the T-cell, recognition of the antigen to continue and go forward. So in the next segment, we'll take the leap into clinical data and explore recent evidence on immune checkpoint blockade and deficient mismatch repair, microsatellite instability high colorectal cancer. Stay with us to find out more about the potential of immune therapy in colorectal cancer and how pathologists and oncologists can work together to integrate immune therapy into clinical care. Welcome back. Last time we left off discussing the rationale for immune therapy in colorectal cancer, particularly in deficient mismatch repair and microsatellite instability high tumors. Although progress in finding a role for immune therapy in GI cancers has been slow compared with other diseases such as melanoma and lung cancer, we do have now some useful evidence on immune checkpoint inhibitors in settings such as colorectal cancer and other gastrointestinal cancers. We'll now turn to the evidence on anti-PD-1 agents such as nivolumab and pembrolizumab in colorectal cancer. Let's begin by reviewing the mechanisms of action of checkpoint blockade. As you can see on this slide, what we demonstrate here is actually the interaction between the CTLA-4 and PD-1, with CTLA-4 on the left and PD-1 on the right. What is key to notice here is that CTLA-4 actually is occurring more on naive T cells, and PD-1 is actually occurring more in engaged T cells in the peripheral tissues. And so these T cells are really T cells that have actually already recognized an antigen and are now being turned off by PD-1, PD-L1 ligand. And so these agents really are reactivating an already engaged T cell recognition that exists in the periphery within these tumors. With the validation of PD-1 axis immune therapy in recent years, it's become apparent that PD-L1 expression in settings such as lung cancer is a relevant predictive biomarker. However, we do have a good deal of evidence that this is not the case in colorectal cancer, whereas we have discussed deficient mismatch repair or microsatellite instability high appears to be the predictive biomarker instead of PD-L1 expression for PD-1 inhibitor activity. As we can see here in a recent study by O'Neill and colleagues, there appeared to be no preferential efficacy with PD-1 inhibitor pembrolizumab in a PD-L1 positive selected population of colorectal cancer. In fact, the one responder that was seen was actually a patient with microsatellite instability high. We do however, have a growing body of evidence on checkpoint blockade in microsatellite instability high colorectal cancer. Let's now turn to the recent CheckMate 142 phase 2 study, which investigated the efficacy and safety of nivolumab with and without ipilimumab in patients with metastatic, deficient mismatch repair, microsatellite instability high colorectal cancer. Here you can see the schema for this study in which monotherapy and a combination therapy was explored, and at present we'll talk about the monotherapy nivolumab in 74 patients with microsatellite instability high colorectal cancer. So what results do we see in terms of response? Well, here the data are from the 74 patients with nivolumab monotherapy, and what can be seen is there's a roughly 30% response rate and a 40% stable disease rate in these patients. To further elucidate the benefit in regards to stable disease and response, I'd like to show you the spider plot. And this really actually gets at this issue of durability. So what you can see by these lines, the blue, stable disease patients, and the red, patients that have actually now come off therapy, but also have benefited. You can see that all patients with stable disease and partial response really have a long durability of benefit that now extends out many weeks. In addition, this same benefit is demonstrated here in the swimmer's plots, which also shows this same benefit in regards to durability. And so the interesting points here is that up top are the patients that are responding, at bottom are the patients that have stable disease. The circles are patients that have come off therapy, and the black triangles are patients that remain on therapy. And what's really interesting to see here is that the majority of patients that are responding are still on therapy, and the majority of patients that have stable disease after a decent initial interval of approximately 3 to 4 months are also still remaining on therapy, really stressing this issue that with clinical benefit, patients seem to retain that clinical benefit going forward with this therapy. So here's just a case to kind of further elucidate this benefit. So this is a patient on the CheckMate 142 study that was treated with single-agent nivolumab who had a partial response to therapy. However, due to rectal pain, concern for rectal progression occurred, and the patient received radiation and then a resection of the primary. The patient then still had benefit in his liver lesions after that and was continued on therapy post-progression with single-agent nivolumab. And then later on, the patient then developed issues related to his rectal surgery with an anastomotic leak and had to go back to surgery. And at that time, 2 responding liver metastases were resected in this patient. The pathology from these 2 liver resections are shown here on the slide. And I'd like to actually now ask Dr. Taggart what she's seeing in regards to these pathology micrographs.
Thanks, Michael. This is a common finding that we see in treated tumors. We do measure treatment response, and certainly clinically, radiologically, you can tell that the tumor is responding, and there are a number of ways that the radiologist can show that there's morphologic changes in the tumor to show response. But really, to get a pathologic complete response, we have to look at every section of the tumor and make sure that there are no neoplastic cells remaining. What we see here are sections of the tumor that show fibrosis and calcification. Other things that we can see are mucinous pools and necrosis. But the thing that we need to see is that all of the neoplastic cells are completely gone to call it a pathologic complete response.
Thank you, Melissa. Let's now turn to other findings from the CheckMate 142, including progression-free and overall survival. Survival outcomes with nivolumab appeared durable in the population, with a 12-month overall survival rate of 73.8% and a 12-month progression-free survival rate of 48.4%. We also observed reductions in target lesions regardless of PD-L1 expression and regardless of KRAS mutation status or BRAF mutation status, and regardless of Lynch syndrome. There were also very interesting patient-reported outcomes observed in this trial. What you see here is actually 2 patient-reported outcome surveys, the EORTC QLQ-C30, which is a cancer-specific patient-reported outcome, and also the EQ-5D, which is actually a non-cancer-related total population-based assessment of quality of life. So the key points here in regards to kind of the EORTC is that you can see that all the different subscales here for global health status, fatigue, appetite loss demonstrated a very quick and rapid improvement with 10 points representing a clinically relevant benefit. And then you see the EQ-5D. And this is actually very interesting because this demonstrates that patients have improvement in their overall functioning that actually approximates what we would consider the population norm for patients that were in this study. So now I'd like to go forward and actually talk about how well tolerated the therapy with nivolumab was in patients. And so here you see the safety profile, which is really consistent with other profiles and safety regarded signals that have been seen in other earlier studies in other tumor settings. So here, 5 patients experienced 1 or more adverse events leading to discontinuation, including abdominal pain, increased ALT, colitis, acute kidney injury, stomatitis, and vomiting. No deaths were reported due to study drug toxicity. So now that we've talked about the data from the CheckMate 142 featuring nivolumab monotherapy, I'd like to now touch base and transition to actually the data that exists out there in regards to single-agent Pemberlism AB in deficient mismatch repair colorectal cancer. So this study was actually explored colorectal cancer and non-colorectal cancer with Pemberlism AB at 10 milligrams per kg IV every 14 days in actually 3 cohorts. So the initial cohort, or one of the cohorts, was mismatch repair deficient colorectal cancer. There was a mismatch repair proficient colorectal cancer, or microsatellite stable colorectal cancer. And then there was also a mismatch repair deficient non-colorectal cancer cohort that included other cancers that had deficient mismatch repair. And so what you can see here from the initial report is actually looking at the efficacy of the Pemberlism AB across these 3 different cohorts. And what you can see is that in the mismatch repair deficient colorectal cohort, there was a 40% response rate and 90% disease control rate. In addition, in the mismatch repair deficient other tumor type cohort, so other tumors that are MSI high that aren't colorectal cancer, again, there was a high overall response rate of 71% and a disease control rate of 71%. Now, marked difference was seen in those patients with proficient mismatch repair where there was no responses seen. Here we can see the biochemical and radiographic response reported in this study. What you can see in the first figure up top is actually the CA response, and then below you see the waterfall response in regards to radiographic tumor changes. In particular, what's important to focus upon is really the deficient mismatch repair cohorts. And clearly in these two figures, you can see that those cohorts are really the cohorts that are benefiting, whereas the proficient mismatch repair or microsatellite stable colorectal cancers are not benefiting from single-agent pembrolizumab. In addition, it was clear that patients with deficient mismatch repair colorectal cancer also experienced significant prolonged progression-free survival with pembrolizumab compared to those whose tumors were proficient mismatch repair. And so now we can see the evidence that I just showed you for both nivolumab and pembrolizumab has had an impact on practice guidelines. Currently, the NCCN recommends nivolumab or pembrolizumab as treatment options in patients with metastatic, mismatch repair deficient colorectal cancer in second-line or greater therapy. Additional clinical trials are ongoing to confirm the benefit of these drugs in these settings and in earlier settings. Recently, the FDA has placed both nivolumab and pembrolizumab under priority review for patients with previously treated deficient mismatch repair or microsatellite instability high metastatic colorectal cancer. So in conclusions, as Melissa and I have discussed, a close working relationship between oncologists and pathologists is essential for the proper assessment of mismatch repair MSI status in colorectal cancer. As Melissa mentioned, there are several recommended methods for MSI testing which should always be performed in appropriate laboratories. In addition, we've seen that deficient mismatch repair or microsatellite instability high status is predictive for PD-1 inhibitor activity in colorectal cancer. This has been borne out thus far in the initial studies of PD-1 checkpoint inhibitors. These agents have recently been included in clinical practice guidelines and are undergoing further testing. Melissa, I enjoyed our discussion today.
Thank you, Michael. I've enjoyed it too.
And thank you all for joining us.
Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerreviewpress.com/MTU. This activity is supported through an educational grant from Bristol-Myers Squibb. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.